Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.
Welcome to Remission Possible, the podcast dedicated to guiding and supporting you on your mission to achieve low disease activity. We understand this challenge wasn't something you asked for, but remember, you're stronger than you think, and you deserve the opportunity to regain control and live your best life. In this episode, we'll talk about disease control in patients with psoriatic arthritis and axial spondyloarthritis. This podcast was created in partnership and sponsored by AbbVie. All guests were compensated for their time. Joining us today are two expert rheumatologists, Dr. Philip Meese and Dr. Alexis Ogdi, along with one of their patients who will share their personal journey. We'll also be discussing best practices for shared treatment decision-making between rheumatologists and patients. Our conversations will be based on the findings of two recently published abstracts from the European Alliance of Associations for Rheumatology, or EULAR, that provide valuable insights into this topic. Whether you're a patient in the early stages of your journey or someone looking for inspiration and motivation, this podcast is for you. So join us on this mission as we help bring you closer to achieving better disease control. Let's get started. I'm Angela DeGrassi, Senior Research Manager for Patient-Centered Research at the Global Healthy Living Foundation, and I'll be your host today. Welcome, everyone, and thank you for joining us on this episode. Dr. Ogdi and Dr. Meese, can you say hello and share what conditions you focus on in your practice?
My name is Alexis Ogdi. I am an associate professor of medicine and epidemiology at Penn in Philadelphia, and I specialize in psoriatic arthritis and axial spondyloarthritis.
And I am Dr. Philip Meese, a rheumatologist with many years of experience in treating patients with various rheumatic conditions, including axial spondyloarthritis and psoriatic arthritis. And I'm based at Providence Swedish Medical Center, where I direct rheumatology research.
Great, thanks so much. Dr. Ogdi, let's start with you. Can you please briefly explain what prompted you to research the burden of uncontrolled disease despite treatment with tumor necrosis factor inhibitors, or TNF inhibitors, in axSpA? And can you remind us, what does axSpA stand for?
So first of all, axial spondyloarthritis is the longer term for axSpA. And just to give you a little background on that, axial spondyloarthritis used to be also called ankylosing spondylitis, and those terms do overlap a little bit. Axial spondyloarthritis has two subsets. One is called non-radiographic, one is called radiographic, and radiographic axSpA is ankylosing spondylitis. So I won't go into too much more detail about that, but just know that the broader category we call axSpA. So why were we interested in studying uncontrolled disease in axSpA and PSA? Actually, we'll come to that in a little bit. But one of the reasons was that we see a lot of patients who don't have fully controlled disease. And in fact, it ends up being a little bit rarer to see the patient who's well controlled than it is to see the patient who's uncontrolled. So the idea in this abstract was to understand what proportion of patients on a TNF inhibitor are still having active disease.
Thanks, Dr. Ogdi. Thanks for clarifying that. Same question for you, Dr. Meese. Can you please tell us what prompted you to research the burden of uncontrolled disease despite treatment with TNF inhibitors in psoriatic arthritis, or PSA?
Sure, Angela. And I agree completely with Alexis's commentary about axial spondyloarthritis. So one of the paradigms that we aim for in treatment of rheumatic diseases is treating to the target of either low disease activity or remission. And this is possible to achieve with some of the advanced medications that we have these days to truly treat inflammation and hopefully stop structural damage progression in our rheumatic diseases. Psoriatic arthritis is a disease which occurs in nearly 1% of the U.S. population. Psoriasis, which is present in about 3% of the U.S. population, begins in a patient's 20s or 30s, and then later on, about a third of patients with psoriasis will develop an arthritis component. This is characterized by not only arthritis, meaning inflammation, pain, stiffness, potentially destruction of joints, but also inflammation and pain where tendons or ligaments attach to bone, like the Achilles tendon in the heel, One can also see inflammation of a whole digit, which we call dactylitis. We also see inflammation and pain arising in the spine. These are all different clinical domains, as we call it, of psoriatic arthritis, in addition to skin psoriasis and nail disease. So it's our goal to try to get all of these clinical domains into remission, where it's not active anymore, or in a very low state where it's not impacting the patient so much. So we have metrics for this, including, for example, achievement of something we call minimal disease activity or very low disease activity. And this is what we were trying to study in the Core Evitas registry, which has several thousand patients with psoriatic arthritis who are being followed over time. And we're looking at patients who are starting a TNF inhibitor, which is one of the main kinds of treatments that we use for this disease, and seeing who can achieve this state of low disease activity or remission. How many patients are truly doing that? Because that's our goal.
Thank you both for sharing your research. Now, let's bring in our patient, who will remain anonymous for privacy reasons. Can you please introduce yourself and share your disease journey with us?
Hi, yes, I'm 37 years old. In July of 2016, I took a very short flight to another area of Washington State. And when the flight was completed, my knee was the size of close to 2 softballs. It was swollen. I'd never experienced this before. When I got back from my trip after a couple days, I had the same type of swelling and intense pain. The swelling was so great that I couldn't actually bend my knee. I went to go see my primary care provider, who referred me to physical therapy, which wasn't very effective because I wasn't able to bend my knee. And then multiple scans were taken, and I ended up being referred to a orthopedic surgeon who scheduled surgery to go in and do kind of an exploratory surgery to figure out what was happening in my knee. That surgery took place in November of 2016. After that surgery, I was immediately referred to Dr. Meese. I came to my first appointment with Dr. Meese, and I remember distinctly that I was crying because I was worried that I would never be able to be myself again. He diagnosed me at that point with suspected rheumatoid arthritis because the swelling was located just in one joint on one side. And I began my TNF journey, which spanned multiple medications, multiple years, just trying to figure out what would work. As time went on, in 2019, I developed what I thought at that point was just eczema, but it became increasingly painful and hard to deal with. And I went back to Dr. Meese and said, I'm having these skin issues. What do we do from here? And he ordered a biopsy to be done through the dermatologist's office. And at that point, my diagnosis was then psoriatic arthritis. I was put on medication, and that worked well. My skin seemed to be better. My arthritis seemed to be better. We did notice a little bit that the pain and the swelling joint-wise was beginning to spread to my other knee. So initially it was on my right and then my left, and starting to feel some discomfort in my ankles as well. The medicine just didn't work for me anymore. I really struggled. It just felt like more joints were becoming impacted by pain and stiffness and swelling. I had a couple bouts on steroids, and it just wasn't really resolving. It almost felt untreated at that point. And I went to see Dr. Meese and figured out the next step. I found relief for the arthritis. It has really opened the possibility to me to be able to feel like I can do more. I've started running again, which is something I never thought I would get to do. And I feel so much more engaged with my young family. I have 2 little boys, and they have all the energy. And I feel like aside from just, the sleep deprivation of being a parent, I can keep up with them physically more than I really thought I'd ever be able to do.
That sounds really challenging what you went through, and thank you for sharing that with us. It really is a journey to get to the right treatment. Can you just talk a little bit about when you did make the change to a new medication, what improvements did you feel, and how did your quality of life change after switching from a TNF inhibitor to a different type of medication?
Yeah, of course. I had been on many TNF inhibitors over the years. When the decision was finally made to switch, it was because I wasn't finding the same level of relief. I was fortunate enough to have a great partnership, with Dr. Meese, who talked me through that change. And the level of relief I have right now is something that I've never experienced. My inflammation markers are lower than they've been since they've started testing my blood at this point. I feel like I can be myself again without worrying about the impact to my joints.
I'm really happy you got connected to a treatment that works best for you. And I think that's a really hopeful message for our patient community. I want to talk to Dr. Ogdi and Dr. Meese. Is this a story that sounds familiar to you? Can you tell us about your experience with patients who struggle with suboptimal disease control, which we'll define here as, despite treatment, having symptoms like pain, stiffness, and fatigue that might impact daily life? I'll start with you, Dr. Ogdi.
So first of all, when I'm thinking about a patient who's not doing well, the questions are what components are not doing well? And then I kind of put them in two bins. One is inflammation and one is not related to inflammation. So for example, if they had swollen joints or active skin inflammation or active uveitis or inflammatory bowel disease, or on MRI, we actually see that there's still inflammation that's fine, that goes in the inflammation bucket. But all the other symptoms like not functioning well, having more long-lasting pain, difficulty sleeping, fatigue, those things can be really multifactorial. And so they may not be related to inflammation or indirectly related to inflammation. Obviously, if you get someone's inflammation fully under control, most of those things get better, but actually a lot of them may persist. So the first thing I'm doing is sorting out what is related to the inflammation, what is not. Then I can make decisions about how I'm going to target those things. So for example, if it's related to physical function or fatigue, then physical activity and physical therapy may be a really good thing for that person. For the inflammation, that's where we're talking about switching therapy. So the first question is, how much active inflammation is there, and will that get better when I switch therapies? And sometimes it's not about TNF versus non-TNF, it's just about changing to something new, but you need to know that what you're actually treating is inflammation. I think a lot of times we end up cycling through therapies as a way to get things better, but that doesn't address all those non-inflammatory symptoms. So we just have to make sure that we're being very clear about what we're addressing with medication switches.
That's really insightful. So knowing which of your symptoms are caused by inflammation would be something that's really important for a patient to know.
Exactly, and to know that it's not always easy to parse out. So having that conversation with the rheumatologist is important. And then doing all the other things that I kind of call the wellness things, like exercise, making sure you're getting good sleep, stress management, depression or anxiety, if those are a part of what's going on for you right now, managing those with either a therapist or a medicine or talking to a psychiatrist, for example. All those other pieces have to be in check too. The other thing is diet. The way you eat, for example, may impact inflammation. Not sleeping can impact inflammation. So sometimes it's a two-way street, and figuring out how those things are all tied together is really important.
Great, thank you. That was really helpful. And what about you, Dr. Meese? Can you please share your experience with patients who struggle with getting their disease under control?
I think this patient's journey is really quite important and illustrates a number of features that are important for patients to know about. Think back. She began with a single joint that became swollen and really painful and limited her function, and it came out of the blue. There was no injury. It just happened in a young individual. So first of all, that's creating alarm bells, an inflammatory arthritis occurring out of nowhere. Then the arthritis actually became a little bit more severe, ultimately it impacted her left knee and other joints as well. And then, interestingly, completely different clinical domains emerged. And now we understood that instead of this being rheumatoid arthritis in an oligoarticular fashion, that it is now psoriatic arthritis. And we now confidently make that diagnosis based on the fact that she had active psoriasis and was one of the 3 out of 10 that with psoriasis will have psoriatic arthritis. So I like to think of these clinical domains like an orchestra. I'm a cellist, by the way, so I know what it means to, at times, have a solo piece within the orchestral movement, but also at times when I'm playing with all of the other sections in the orchestra fortissimo. And so in her case, we had various sections of the orchestra playing, and our goal in figuring out optimal treatment is, can we find a medication that will treat all of these domains effectively? And fortunately, in her case, we were able to do so initially with the TNF inhibitors, but then they lost benefit and weren't completely beneficial along the way. And then we came to switching And I would say that we've achieved this goal of getting into a state of low disease activity, which is allowing her to really function normally in life and try to keep up with her kids who are a rambunctious sort.
Can I just add to that too? We all want relief, but we all have this goal of returning to our prior selves. There's the diagnosis that comes down and then your life changes. And then you try medicine after medicine and they work for a little bit or they don't. But you almost think it's impossible to get back to being yourself again, whatever that form is. And I'm just really thankful that I have had access to a great team to help me achieve that, but I really never thought it was possible. And it's really exciting to me right now. And I'm really excited to be able to do whatever I can now to keep up with my kids and to enjoy life as a 37-year-old should be doing right now.
Thanks for adding that. And that made me really happy to hear. I'm really glad you two are connected and that you're getting the care that you need to feel like yourself again. I think that's the most important thing. And thank you, Dr. Meese, for that metaphor. I always appreciate a good metaphor. It helps to make complicated things a little bit easier to understand. And it's cool to learn that you play the cello too. Thanks for sharing that. So, Dr. Meese, Dr. Ogdi, can you elaborate on findings from the abstract we mentioned earlier? Dr. Ogdi, do you want to go first?
So in this study, one of the things that we wanted to understand was what are the remaining symptoms and how many patients experience remaining symptoms after a period of follow-up. So in this study, we examined patients who were starting a TNF inhibitor, and then we followed them over subsequent follow-up visits up to 12 months and compared patients who achieved disease control, which we use this outcome measure called the BASDI, a patient-reported outcome measure, to define, versus those who didn't. And so what we found is that 8 of 10 patients in that group failed to achieve disease control at 6 months. And of those, 9 of 10 then failed to go on at 12 months and achieve it. That kind of is understandable. So if you don't get there in 6 months, the likelihood of staying on the same therapy and still getting better at 12 months is low. So I think one of the points there is that if someone's not doing well at 6 months, we should probably be doing something different. And so if you're the patient and you're sitting there with your rheumatologist and you've been on a therapy for 6 months and you're not doing very well, the question is, we got to do something different. What is it that we're going to do different? Are we going to switch the therapy? Or are we going to try something different like a physical therapy, a medicine for pain, or any number of other activities that you might try to get better?
Great. So 6 months, that's the red flag. If you switch medications, you've been on it for 6 months, and you're not seeing those improvements you were hoping for, then it's time to have that conversation with your doctor and see what else you can do and what comes next in your treatment plan.
Exactly. So, when we started medicine, we often say 3 to 6 months. We say 3 months is where you should feel something different. By 6 months, most people have achieved what they're going to achieve on that medicine. And again, the next step might not be switching therapies. It might be doing something else.
I just want to chime in on that too. I'm so glad to hear, the points that were made about 3 to 6 months, but I will say from a patient perspective, 6 months is a long time. 6 months is a lot of life. And while you're waiting to be able to get back to some form of your life before, 6 months can feel much longer, and it can make you feel a little bit less like there's hope to getting back to full functionality again.
That's so true. So much life can happen in 6 months. So thank you for mentioning that. Dr. Meese, can you elaborate a little bit on the findings from the abstract we mentioned earlier?
Sure. So the CorEvitas registry that we derived this data from follows both patients with axial spondyloarthritis as well as psoriatic arthritis. So Alexis just summarized the data that we found in the axial spondyloarthritis group of patients, and very similar findings were seen in the psoriatic arthritis populations. These are 2 different abstracts and yet very similar findings. So the way it was done was that patients who were starting a TNF inhibitor were assessed at baseline, and then again at the standard registry follow-up visits, which were at the 6-month time period and then the 12-month time period. And we ask a simple question. How many patients starting a TNF inhibitor were able to achieve a target of minimal disease activity at 6 months? And if they had or had not at 6 months, what was their situation at 12 months? The minimal disease activity criteria includes certain thresholds. There are a total of 7 of them. So, for example, if a patient now has less than or equal to 1 tender or swollen joint, if their pain score is low, if their physical function score is good, if their skin psoriasis score is low, their enthesitis score is low. Enthesitis is wherever tendon or ligament that's inflamed and painful is present. So these are optimal thresholds to get to. And if the person has 5 out of the 7 items that are part of this criteria, then they're in a state of minimal disease activity. So what we found was that 7 out of 10 patients were unable to achieve this threshold of MDA achievement at the 6 or 12-month mark. There were a certain percentage of patients, a small percentage, that didn't make it at 6 months but could at 12, so it's worth checking that possibility. But still, the majority did not. And this really speaks to the fact that we have a ways to go in our optimal treatment approaches to getting patients into a state of low disease activity.
That's really insightful. Thank you for pointing that out. I think it's good to know what the goal is or what really defines low disease activity. Now, let's discuss best practices for shared treatment decision-making between rheumatologists and patients. Dr. Meese, can you start us off? How do you incorporate patient preferences and values into your treatment decisions?
So there's a phrase that we use in medicine called shared decision-making. And I think perhaps in older times, there was this sort of hierarchical approach to medicine where what the doctor thought and made decisions based on his or her judgment went without necessarily getting much input from what might be the patient preferences here. We've learned that it's really valuable and really important to, from the very beginning, always incorporate the patient's perceptions, explore their understanding of their disease process, listen to what their major concerns are. Sometimes I will hear from a patient, for example, "Doc, I can handle the pain, but it's this fatigue that sets in because of this inflammation condition that really it's mind numbing." Or another patient may say, what's really important to me is that I know that a medication I'm using is halting structural damage progression because I can handle the pain at the moment, but I want to know that I'm not going to be crippled down the road. There are other goals that the patient may have, getting better sleep quality or being able to chase their kids around the block. So I think it's very important to just listen. What is it that's important to the patient? Because it may be slightly different from what you think is most important. So then when I'm introducing the idea of a medication to a person, then I will sit down. I might even pull out my computer and show them some graphs of data from clinical trials showing the potential efficacy of a medication. I will also parallel that with a discussion about safety. So what are the potential risks in using a medication like serious infection, or might it cause a malignancy down the road, or other issues that might come up? So it's very important to fully explore all of that. We want to ask, how do you feel about giving yourself an injection? What's your love or hate of needles? What do you think about getting an infusion? What do you think about taking an oral medication? So these are all lifestyle choices that the patient will want to weigh in on. Some of our medicines might have liver toxicity, and so we need to counsel about restriction of alcohol use. Well, some patients may not want to restrict their favorite glass of wine at dinner with their spouse. So these are all things that are part of the shared decision-making process. And so what I often do is we'll describe a bunch of medications to choose from and have the patient go home, think about it, discuss it with their partner, go to Dr. Google and read about it, and then come up with a second conversation in which we say, okay, this seems to be the one that fits best with your desires. Let's see whether we can get it approved or not. And that's how it goes.
There's so many factors that you just listed, and it sounds like no two patients are the same, as you have to treat everyone truly as an individual when you're making these decisions.
That's absolutely right.
Dr. Ogdi, can you share your perspective on how patients can actively participate in shared decision-making?
That's a great question. I feel like it's often different for each patient. One of the questions that I like to ask is, if everything was good right now, what would that look like for you? Or what are some goals that you would want to achieve? If the answer is, I want to be able to play basketball, as one of my patients said, or I want to be able to walk, or I want to be able to, up and down the street, or I want to be able to play on the ground with my kids or grandkids, then physical therapy might be the right thing to do there, for example. And so we might really prompt things that are going to get function higher. So I think, first of all, getting a sense of, if you could be living your best life right now, what does your best life look like? That's actually really helpful to know. I would tell you most doctors don't ask that question, but if you come with, this is what I want to do, then we can help say, oh, I can help you with that. What we're trained to do is look at the number of swollen joints, the number of tender joints, the amount of skin that's involved, for example, and then make a treatment plan based on that. But that doesn't always get to your goals as a patient. So I think number one is knowing that we're not trained this way. And so if you can help us out by telling us what you need and what you want, that will actually bring things a long way.
That was such a great answer. It's great to hear there's such a patient-centered approach to collaborating with your rheumatologist. Thank you both for highlighting the importance of shared decision-making. At GHLF, we understand the importance of sharing your progress with your doctor and have even developed a platform called Patient Spot to help members better understand and communicate their symptoms and treatment progress. I could talk about that app all day, but let's get back to it. Dr. Ogdi, as we wrap up this conversation, do you have any final thoughts or recommendations for patients and healthcare providers?
Absolutely. I think people go into rheumatology because they want to help people feel better. I think one of the tricky things is that the way our healthcare system is set up is that we have a very limited amount of time and have the resources often to answer lots of messages and things like that. So it's really helpful if the patient can be very succinct and clear about what their needs are up front. And so that's where you can drive your own care by being really efficient and helpful about, saying what you need.
So driving your own care, that means that patients really need to be their own advocate for themselves.
Exactly. Yeah, being your own advocate is really important. And doing that in a visit is really important too, so that you're actually having that conversation together.
Great, thank you. Dr. Meese, do you have any final thoughts or recommendations for patients and healthcare providers?
I would also like to emphasize the importance of open and honest communication between patients and healthcare providers. Patients should never hesitate to voice their concerns or ask questions. It's also essential for healthcare providers to actively involve patients in the decision-making process and consider their preferences and values. By working together, patient and clinician, we can improve treatment outcomes and enhance the overall patient experience. So I want to really thank you all for having this opportunity today to mix it up with our patient, because her journey has been so remarkable, emotionally trying, ups and downs, now in a path that looks like it's going to be a really good one for her for functioning in the world and functioning with her family and work. And so being able to be part of that journey as a physician is just really rewarding. It's what we get up for in the morning and go to work. It's so inspiring. So I want to really thank her a lot for sharing this story with us.
That's so sweet, and it's great to be in the room with you too. Dr. Meese, Dr. Ogdi, and our patient, thank you so much for sharing your insights and experiences. This has been a really enlightening conversation on the challenges of disease control with TNF therapies and the importance of shared treatment decision-making. We hope this discussion has provided valuable information to our listeners.
Awesome. Thank you.
Thanks so much, Angela, for having us. It's been great.
I appreciate the opportunity to share my journey through my conditions and my treatment, and hopefully this helps other people open lines of communication with their provider and find a path that works for them. I'm hoping other people find relief. There's a saying that a lot of people tend to say, or who have faced autoimmune conditions, and it's giving everyone a gentle hug and hoping that they find relief. And I really hope that people are able to do that and kind of experience a good trajectory and a good path forward like I've been able to.
Thank you all for sharing your insights and experiences and for giving us a true and honest picture of what it's like to cope with uncontrolled disease and how to work together as a patient and provider to reach a better treatment option and quality of life. And to our listeners, thank you for joining us on Remission Possible, the podcast where we explore the path to low disease activity and improve well-being. We hope the stories, insights, and guidance we shared have inspired and empowered you along the way. If you've liked what you've heard, be sure to rate our podcast, write a positive review, and spread the word by sharing with your friends and family. It'll help more people like you find us.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.